Appendicitis. Overview and Management Q&A Introduction. Welcome to the Everything Surgery podcast question and answer session. This Q&A will provide a comprehensive overview of appendicitis, including its epidemiology, anatomy, diagnosis, management, considerations for special populations, and neoplasms. Pause the video after the word question to attempt answer. Let's begin. Prevalence and incidence. Epidemiology. Dietary factors question. How common is appendicitis and what proportion of the population is affected? Answer. Appendicitis is the most frequent urgent or emergent general surgical operation in the United States, impacting between 6 and 7% of the population. Question. At what age does the incidence of appendicitis typically reach its highest point? Answer. The incidence of appendicitis peaks during the second decade of life. Question. Are there any dietary patterns that may contribute to the development of appendicitis? Answer. A diet low in fiber and high in fat, typically associated with Western eating patterns, may increase the risk of developing appendicitis. Anatomy and embryology. Development, function, consequences of removal question. How does the appendix develop during gestation and where is it typically located? Answer. The appendix develops from the cecum at 8 weeks of gestation and becomes a tubular structure situated in the right lower quadrant of the abdomen. Question. What potential roles does the appendix serve within the human body? Answer. The appendix may have a function in the immune system and could act as a reservoir for beneficial gut bacteria. Question. What are the possible consequences of removing the appendix? Answer. Removal of the appendix may be linked to poorer outcomes in infections caused by Clostridium difficile and could be associated with an increased risk of prostate cancer. History of appendicitis. Early surgery. Clinical description. Surgical advancements question. When was the first appendectomy performed and by whom? Answer. The first appendectomy was performed in the year 1735 by Claudius Amyand. Question. Who formally described appendicitis and what did this description include? Answer. Reginald Heber Fitz formally described appendicitis in 1886, outlining its clinical features and emphasizing the necessity for surgical removal. Question. What have been significant advancements in the surgical treatment of appendicitis? Answer. Notable advancements include McBurney's incision, introduced in 1894, and the laparoscopic appendectomy, first performed in 1982. Pathophysiology and Bacteriology. Causes. Bacterial overgrowth. Infection types question. What is the primary cause of appendicitis? Answer. The main cause of appendicitis is luminal obstruction, which leads to increased pressure, impaired venous drainage, and potentially perforation of the appendix. Question. How does bacterial overgrowth occur in appendicitis and what risks does it pose? Answer. Bacterial stasis distal to the obstruction can result in bacterial overgrowth, increasing the risk of infection. Question. What types of bacterial infections are commonly associated with appendicitis? Answer. Appendicitis usually involves polymicrobial infections that include both gram-negative bacteria and anaerobic organisms, necessitating broad-spectrum antibiotic coverage. Differential diagnosis. Diagnostic considerations by age and sex question. In which patients should appendicitis be considered as a possible diagnosis? Answer. Appendicitis should be considered in all individuals without a prior appendectomy who present with acute abdominal pain. Question. How does age and sex influence the differential diagnosis of acute abdominal pain? Answer. Patient age and sex are important factors that help narrow the differential diagnosis for acute abdominal pain, as certain conditions are more prevalent in specific groups. Question. What are some examples of differential diagnosis for acute abdominal pain based on age and sex? Answer. The differential diagnosis varies from common conditions such as gastroenteritis in children, to gynecologic issues in women of childbearing age, and malignant diseases in elderly patients. Clinical presentation. Pain location. Symptoms. Atypical presentations question. Where does pain typically begin in patients with appendicitis and how does it progress? Answer. Pain commonly starts around the belly button and subsequently shifts to the lower right abdomen as the appendix becomes inflamed. Question. What other symptoms may accompany appendicitis? Answer. Additional symptoms may include loss of appetite, nausea, vomiting, diarrhea, or constipation. Question. Are there any atypical presentations of appendicitis? Answer. Yes. Atypical presentations can occur, such as flank or back pain in individuals with a retroperitoneal appendix, or suprapubic pain in those with the tip of the appendix located in the pelvis. Physical examination. Patient appearance. Abdominal findings. Diagnostic signs. Question: how do patients with appendicitis typically present during a physical examination? Answer: patients often appear unwell, may lie still due to pain, and can exhibit fever, rapid heartbeat, and mild dehydration. Question: what are common findings on abdominal examination in appendicitis? Answer: tenderness and guarding in the right lower quadrant, especially at McBurney's point, are typical, and rebound tenderness suggests localized peritonitis. Question: are there specific physical signs that aid in the diagnosis of appendicitis? Answer: signs such as Rovsing's, obturators, and psoas signs may indicate peritonitis, but are not specific to appendicitis. Rectal and pelvic examinations may be needed to exclude other conditions. Laboratory studies. Test limitations. Scoring systems. Comprehensive assessment. Question: how should laboratory tests be used in the diagnosis of appendicitis? Answer: laboratory tests, including white blood cell count and biomarkers, should support clinical findings but are not definitive for diagnosing appendicitis. Question: what clinical scoring systems are recommended for diagnosing appendicitis? Answer: recommended scoring systems include the Alvarado score, pediatric appendicitis score, appendicitis inflammatory response score, and adult appendicitis score, with the appendicitis inflammatory response score or adult appendicitis score preferred over the Alvarado score. Question: is there a single symptom, sign, or test that reliably diagnoses appendicitis? Answer: no individual symptom, sign, or test is definitive for appendicitis. Diagnosis should be based on a comprehensive assessment of all available information. Imaging studies. Modalities. Findings. Recommendations. Question: what imaging modalities are available for diagnosing appendicitis? Answer: imaging modalities include plain radiographs, ultrasound, computed tomography, and magnetic resonance imaging. Question: what are the advantages and limitations of ultrasound in diagnosing appendicitis? Answer: ultrasound is efficient, avoids radiation exposure, and can visualize an inflamed appendix. Its success is dependent on the skill of the sonographer, with sensitivity ranging from 71 to 94% and specificity from 81 to 98%. Question: are plain radiographs useful for diagnosing appendicitis? Answer: plain radiographs generally lack sensitivity and specificity for appendicitis diagnosis and are rarely helpful. A calcified fecalith may occasionally support the diagnosis, but this finding is uncommon and must be interpreted within the clinical context. Question: what is the recommended imaging technique for evaluating acute appendicitis in adults? Answer: contrast-enhanced low-dose computed tomography is the recommended imaging technique for acute appendicitis evaluation in adults. Question: what are the typical findings on computed tomography in acute appendicitis? Answer: findings include a thickened, inflamed appendix with surrounding stranding, usually greater than 7 mm in diameter, with a thickened wall and mural enhancement. Question: when is magnetic resonance imaging used for appendicitis and what precautions are taken? Answer: magnetic resonance imaging is generally reserved for pregnant patients and is performed without contrast. Classification. Types. Imaging features. Scoring systems. Question: how is appendicitis classified? Answer: appendicitis is classified into acute and chronic forms, with acute appendicitis further divided into uncomplicated and complicated types. Question: what defines uncomplicated appendicitis? Answer: uncomplicated appendicitis refers to inflammation of the appendix without necrosis or perforation, and may be treated without surgery. Question: what are the hallmarks of complicated appendicitis? Answer: complicated appendicitis involves necrosis that leads to or has a risk of perforation, requiring surgical removal of the appendix. Question: what imaging features are associated with complicated appendicitis? Answer: imaging features of complicated appendicitis include the presence of abscess, appendicolith, free air, and free fluid. Question: what are SAS-US and SAS-CT scoring systems and what is their current validation status? Answer: SAS-US and SAS-CT are new scoring systems utilizing ultrasound and computed tomography imaging to distinguish between uncomplicated and complicated appendicitis, but have not yet been externally validated in prospective studies. Treatment options. Management strategies. Decision-making. Question: What treatment options are available for appendicitis? Answer. Treatment options include open appendectomy, laparoscopic appendectomy, robotic appendectomy, single incision appendectomy, percutaneous and transrectal drainage, and non-operative management with antibiotics. Question. What is the initial management for acute appendicitis? Answer. For acute appendicitis, fluid resuscitation and broad-spectrum antibiotics are primary treatments until further management is determined based on severity and patient preferences. Question. How is the best treatment strategy determined for appendicitis? Answer. The optimal treatment strategy is based on the type of appendicitis and incorporates patient preferences. Acute uncomplicated appendicitis. Question. Is antibiotic treatment as effective as appendectomy for uncomplicated appendicitis? Answer. In a major clinical trial, antibiotic therapy for uncomplicated appendicitis was found to be non-inferior to appendectomy, although it had a lower overall success rate. Question. How do quality of life and patient satisfaction compare between treatment options? Answer. Studies indicate similar levels of satisfaction between groups when treatment is successful, but lower satisfaction among patients who experience failure with antibiotic treatment. Question. What are the risks associated with non-operative management of appendicitis? Answer. Non-operative management carries a risk of recurrence and progression to complicated appendicitis, though it may have a lower initial cost. Question. What were the findings of the CODA trial regarding antibiotics versus appendectomy? Answer. The CODA trial found that antibiotics were non-inferior to appendectomy at 30 days for uncomplicated appendicitis, but 29% of patients required appendectomy within 90 days. Question. How does the presence of an appendicolith impact treatment decisions? Answer. Patients with an appendicolith have a higher risk of requiring appendectomy and experiencing complications if managed non-operatively. Question. What did the COMA trial reveal about recurrence rates after non-operative treatment? Answer. The COMA trial reported a 25% recurrence rate after non-operative treatment, with lower quality of life at 1 year compared to those who underwent appendectomy. Question. What are the primary treatment options for uncomplicated appendicitis? Answer. Both antibiotics and appendectomy are considered safe and effective treatments for uncomplicated appendicitis. Question. How important is shared decision-making in choosing a treatment for appendicitis? Answer. Shared decision-making is crucial, as patients' preferences and values must be considered when choosing between antibiotics and surgery. Question. What factors should be discussed with patients making a treatment decision? Answer. Risks of recurrence, potential neoplasm, and surgical complications should be thoroughly discussed with patients. Question. What role does the presence of an appendicolith play in treatment decisions? Answer. The presence or absence of an appendicolith is critical in deciding between surgical and non-surgical management. Question. Is there a tool available to assist patients and clinicians in making treatment decisions for appendicitis? Answer. Yes. A decision aid tool is available to facilitate shared decision-making between patients and surgeons. Question. What are the main surgical and non-surgical treatments for appendicitis? Answer. Surgical options include open or laparoscopic appendectomy, while non-surgical treatment consists of a 10-day course of antibiotics. Acute complicated appendicitis. Question. How should proven or suspected complicated appendicitis without abscess or phlegmon be managed? Answer. Surgical intervention is the recommended treatment for proven or suspected complicated appendicitis without abscess or phlegmon. Question. What considerations are important during appendectomy for complicated appendicitis? Answer. The surgical technique is similar to that used for uncomplicated appendicitis but requires gentle handling of the appendix and surrounding inflamed tissues. Question. What is the recommended duration for postoperative antibiotics after appendectomy for complicated appendicitis? Answer. Postoperative antibiotics should be administered for a maximum of 4 days, with recent data supporting a duration of only 2 days. Question. What are the symptoms of a postoperative abscess following appendectomy? Answer. Symptoms may include fever, elevated white blood cell count, pain, and delayed return of bowel function. Question. How is a postoperative abscess diagnosed and treated? Answer. Diagnosis is achieved with a computed tomography scan using intravenous contrast. Treatment involves antibiotics and percutaneous drainage or, if computed tomography drainage is not possible, laparoscopic, transrectal, or transvaginal drainage. Acute appendicitis with abscess or phlegmon. Question. How is acute appendicitis with abscess or phlegmon managed? Answer. Management is individualized based on presentation and factors such as the presence of peritonitis. Question. What are the options for non-operative management in this scenario? Answer. Non-operative management, which is often successful when laparoscopic expertise is unavailable, includes antibiotics and potentially percutaneous drainage. Question. When is operative management preferable for acute appendicitis with abscess or phlegmon? Answer. Operative management may be preferred in experienced hands, as it can reduce length of stay and readmissions but carries a higher risk of complications. Question. How long should antibiotics be administered according to guidelines? Answer. A 7-day course of antibiotics is recommended, consistent with the Infectious Diseases Society of America guidelines for intra-abdominal infection. Question. What is interval appendectomy and when should it be considered? Answer. Interval appendectomy is considered after successful non-operative treatment to prevent recurrent appendicitis and associated risks, but is not routinely recommended due to potential recurrence and costs. However, it may be justified in patients with an appendicolith identified on computed tomography. Question. What led to the stoppage of a trial investigating interval appendectomy? Answer. The trial was halted due to a high rate of neoplasm in the interval appendectomy group, particularly among patients older than 40 years. Question. What follow-up is recommended for patients over 40 who do not undergo interval appendectomy? Answer. Routine follow-up should include colonoscopy and full-dose contrast-enhanced computed tomography following non-operative management of complicated appendicitis. The normal-appearing appendix at operation. Question. What should be considered in cases of negative appendectomy? Answer. Thorough abdominal evaluation is essential to identify other potential causes of pain. Question. Is appendectomy recommended if no abnormalities are found during surgery? Answer. Yes. Appendectomy is strongly recommended to eliminate the appendix as a future cause of right lower quadrant pain. Question. How is appendectomy approached in patients with Crohn's disease? Answer. Appendectomy is generally advisable in patients with Crohn's disease unless the base of the appendix and cecum are involved. Stump appendicitis. Question. What is stump appendicitis and how does it present? Answer. Stump appendicitis is the recurrent inflammation of residual appendiceal tissue at the base of the cecum following incomplete appendectomy. Symptoms are similar to those of acute appendicitis. Question. How is stump appendicitis diagnosed and treated? Answer. Diagnosis can be challenging, with imaging often revealing cecal wall thickening and fluid in the right paracolic gutter. Surgical removal of the remnant appendix is the standard treatment. Chronic appendicitis is a cause of abdominal pain. Question. Is appendectomy beneficial for patients with recurrent right lower quadrant pain? Answer. Appendectomy may be beneficial for patients with recurrent right lower quadrant pain, even if uncomplicated appendicitis resolves without intervention. Question. Should appendectomy be offered for nonspecific lower abdominal pain without radiographic evidence of appendiceal disease? Answer. Appendectomy is typically not offered for nonspecific lower abdominal pain without radiographic evidence. However, it may be considered if diagnostic laparoscopy is performed. Question. What is the role of shared decision-making in considering appendectomy for abdominal pain? Answer. Shared decision-making is essential to weigh the risks against the potential for symptom resolution and the benefit of ruling out the appendix as a pain source. Incidental appendectomy. Question. What is an incidental appendectomy and is it currently recommended? Answer. Incidental appendectomy refers to the removal of a normal appendix during an unrelated procedure. It is not currently recommended due to increased morbidity, mortality, and lack of cost-effectiveness. Question. What function does the appendix serve in the body? Answer. The appendix may play a role in maintaining healthy colonic flora. Laparoscopic versus open appendectomy. Question. What are the advantages of laparoscopic appendectomy compared to open appendectomy? Answer. Laparoscopic appendectomy is associated with a lower risk of complications, reduced morbidity, fewer wound complications, less pain, and a slightly shorter recovery time. Question. What additional benefit does laparoscopic appendectomy offer? Answer. It allows for examination of the entire peritoneal cavity, which is useful for excluding other intra-abdominal diseases. Question. How is an open appendectomy performed? Answer. Open appendectomy involves making an oblique, transverse, or midline incision, delivering the cecum, dividing and ligating the appendix, and managing the stump. Question. What is the surgical positioning and preparation for appendectomy? Answer. The patient is placed in a supine position with the bladder emptied. The abdomen is entered using either the open or optical trocar technique. Question. How is the appendix removed during laparoscopic appendectomy? Answer. 2 additional working ports are placed. The appendix is elevated and divided using a stapler or endoloop. The mesoappendix is divided, and the appendix is retrieved in a bag. Question. What steps are taken after the appendix is removed? Answer. The pelvis is suctioned and irrigated. Trocars are removed, and the wounds are closed. Appendicitis in special populations. Appendicitis in the pregnant patient. Question. How common is appendicitis during pregnancy and what are the diagnostic challenges? Answer. Appendicitis is the most common non-obstetric emergency in pregnancy and often presents atypically. Diagnosis is complicated by nonspecific symptoms, altered physical findings, and unreliable biochemical markers. Question. What imaging strategy is recommended for appendicitis in pregnancy? Answer. Routine imaging, especially ultrasound with graded compression, is crucial for accurate diagnosis due to the significant impact on both mother and fetus. Question. What is the preferred follow-up imaging modality if ultrasound is inconclusive in pregnant patients? Answer. Magnetic resonance imaging is preferred as follow-up, and computed tomography is reserved as a last resort due to concerns regarding radiation exposure. Question. Is laparoscopic appendectomy considered safe during pregnancy? Answer. Laparoscopic appendectomy is the most common approach and is considered safe when performed by experienced surgeons. Question. What surgical considerations are necessary regarding trocar placement in pregnant patients? Answer. Surgeons must consider the height of the gravid uterus to avoid uterine puncture when choosing trocar placement sites. Appendicitis in the elderly. Question. Should appendicitis be considered in elderly patients with acute abdominal pain? Answer. Yes. Appendicitis should be considered a possible diagnosis in elderly patients with acute abdominal pain, even if they have previously undergone appendectomy. Question. What are the risks associated with appendicitis in elderly patients? Answer. Elderly patients are at higher risk for complications due to reduced physiological reserves, impaired immune response, and increased rates of perforation. Question. What are the preferred treatment options for appendicitis in elderly patients? Answer. Laparoscopic appendectomy is preferred, though non-operative therapy may be considered in patients who are too ill for surgery. Appendicitis in the immunocompromised patient. Question. What is the recommended imaging for diagnosing appendicitis in immunocompromised patients? Answer. Computed tomography imaging is recommended for prompt diagnosis and to exclude other conditions. Question. How should appendicitis be managed in immunocompromised patients? Answer. Appendectomy is the recommended treatment in these patients. Question. How might the clinical presentation differ in immunocompromised patients with appendicitis? Answer. Immunocompromised patients may lack typical signs such as fever and elevated white blood cell count. Neoplasms of the appendix. Prevalence. Classification. Management. Question. How prevalent are appendiceal neoplasms and how are they usually discovered? Answer. Appendiceal neoplasms are rare, with an annual incidence of 6 per 1 million people, and are often diagnosed incidentally during appendectomy. Question. What challenges exist in the management of appendiceal neoplasms? Answer. The diverse tumor biology and histopathology lead to widely varying long-term survival rates, which can create confusion regarding classification and management. Question. How are appendiceal neoplasms classified? Answer. Consensus guidelines from the Peritoneal Surface Oncology Group International, American Joint Committee on Cancer, and World Health Organization classify appendiceal neoplasms into epithelial and non-epithelial tumors. Question. What are examples of epithelial and non-epithelial appendiceal tumors? Answer. Epithelial tumors include adenomas, mucinous neoplasms, and adenocarcinomas, while non-epithelial tumors encompass lymphomas and sarcomas. Question. How does classification differ between organizations? Answer. The World Health Organization classifies some tumors as epithelial, whereas the Peritoneal Surface Oncology Group International classifies them as non-epithelial. Question. What is the approach to managing appendiceal neoplasms? Answer. Management involves a thorough approach based on histologic classification, clinical presentation, and risk factors. Clinical presentation. Question. How do appendiceal neoplasms commonly present? Answer. These neoplasms often mimic symptoms of acute appendicitis, but can also be incidental findings during imaging or surgery. Question: why is pathological review important in appendectomy specimens? Answer: pathological review is essential for accurate diagnosis and appropriate management of appendiceal neoplasms. Question: what risk factors and imaging features may suggest an appendiceal neoplasm? Answer: age over 40, immunocompromised status, periappendiceal abscess, and certain imaging characteristics can indicate possible neoplasm. Question: how do appendiceal mucinous neoplasms typically present and what are the management considerations? Answer: these neoplasms often present as mucosals, which may be benign or malignant, and require careful management to avoid rupture and peritoneal seeding. Question: what intraoperative steps should be taken when a neoplasm is suspected? Answer: surgeons should avoid rupturing the mass, look for peritoneal dissemination, and biopsy any suspicious nodules or mucin deposits. Question: what postoperative management is recommended for appendiceal neoplasms? Answer: postoperative management includes reviewing oncologic history and physical examination, performing colonoscopy and cross-sectional imaging, and discussing findings in a multidisciplinary tumor board. Management of primary appendiceal neoplasms by histologic classification. Question: how are epithelial neoplasms of the appendix managed? Answer: adenomas and serrated polyps are usually incidental findings managed with appendectomy, but warrant colonoscopy due to increased risk of synchronous colonic pathology. Mucinous neoplasms are managed with appendectomy, though high-grade atypia requires examination for invasion, and mucinous adenocarcinomas require more aggressive management. Question: what is the treatment approach for appendiceal adenocarcinoma? Answer: treatment includes complete staging with imaging and tumor markers, followed by interval right hemicolectomy, lymph node sampling, and consideration of adjuvant chemotherapy. Less extensive surgery may be sufficient for select patients with T1, well-differentiated tumors without lymphovascular invasion. Question: how is goblet cell adenocarcinoma managed? Answer: goblet cell adenocarcinoma is managed similarly to non-mucinous adenocarcinomas, including imaging, tumor markers, interval right hemicolectomy, lymph node staging, and possibly adjuvant therapy. Question: what are neuroendocrine neoplasms and how are they classified? Answer: neuroendocrine neoplasms originate from subepithelial neuroendocrine cells in the tip of the appendix and are classified as neuroendocrine tumors, neuroendocrine carcinomas, or mixed neuroendocrine non-neuroendocrine neoplasms. Question: what is the role of somatostatin receptor imaging in neuroendocrine neoplasms? Answer: somatostatin receptor imaging is useful for identifying occult or distant disease and monitoring treatment response, but its high cost limits use to select cases. Question: what are the surgical recommendations for neuroendocrine tumors of the appendix? Answer: guidelines recommend simple appendectomy for tumors less than 2 cm in the distal appendix, but right hemicolectomy for incomplete resection, node positivity, or positive margins. Tumors at the base or greater than 2 cm require right hemicolectomy with lymph node staging. Question: are there additional recommendations for hemicolectomy in neuroendocrine neoplasms? Answer: additional recommendations include hemicolectomy for positive mesenteric nodes, base of appendix or mesoappendix invasion, Ki 67 index greater than 20%, or mixed tumor histology. Question: how are non-epithelial neoplasms of the appendix managed? Answer: lymphomas and sarcomas are extremely rare and are typically discovered incidentally after appendectomy for presumed appendicitis. Management of peritoneal dissemination from appendiceal neoplasms. Question: what is pseudomyxoma peritonia and how is it treated? Answer: pseudomyxoma peritonia is a rare condition where a mucin-producing tumor of the appendix ruptures, causing spread of tumor cells and mucinous ascites in the abdomen. The standard treatment is surgical cytoreduction combined with hyperthermic intraperitoneal chemotherapy. Question: what is the prognosis for pseudomyxoma peritonia? Answer: survival rates after treatment vary depending on the histologic subtype, disease burden, and completeness of cytoreduction. Low-grade pseudomyxoma peritonia has a higher survival rate than high-grade disease. Question: what terminology is appropriate for lower degrees of mucin-producing tumors in peritoneal disease? Answer: the term peritoneal carcinomatosis is more appropriate for patients with lower degrees of mucin-producing tumors. Question: How is peritoneal carcinomatosis diagnosed and treated? Answer. Diagnosis typically involves diagnostic laparoscopy to assess candidacy for cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, and to determine disease burden. Systemic therapy is often crucial, and treatment decisions should be made by experienced centers considering all available options, including palliative care. That's a wrap. Thanks for tuning in. If you enjoy our content, please like, share, and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.